Namaste Alrigo. Today we will discuss about some anti-cancer drugs. Okay. So cancer is nothing but a plague of cells within the cell division. It's nothing but the topic of cell and the cell division, where cell undergoes abnormal cell division. So primarily we will talk about some cancer which is also called neoplasia. Neoplasia. Here there is a abnormal and rapid proliferation of cells. Abnormal and rapid proliferation of cells. As I said, it's a game of cell and cell division. Okay. Here, as we know, cell cycle is nothing but a G1, S, G2, M. Any abnormality in these stages, any abnormality in any of these four stages might lead to the rapid proliferation of the cells that leads to the abnormal ones, that is called as cancer. Okay. Some of the cancer might be dangerous as life threatening, and some of the cancers which may be treated continuously with some chemotherapies, and some of the cancer which will be treated with chemotherapy, with the surgery, and with some radiations. So there are many medications nowadays in the oncology field about this cancer. So primarily, if we talk about if any patient go with any cancer disease, if a doctor detects any cancer disease in the patient, then primarily he will suggest the chemotherapy. So primarily we will go with the chemotherapy. That is also called some anti-cancer drugs. In that anti-cancer drugs, if you want to classify the anti-cancer drugs, anti-cancer drugs. So in this anti-cancer drug, here we come about non-cell cycle specific drugs and cell cycle specific drugs. So here, what do you mean by non-cycle as well as this cyclic specific drug? What do you mean by these? Non-cycle as well as cell cycle specific drug. Here, non-cell cycle specific drug, it will the drug which are come under this anti-cancer drug in this category, it will take whole without any specific stage in this cell cycle, either G1, S, G2 or M. It will take whole cell cycle with irrespective of any stage where the cancer is causing. But if we come to know this cancer is caused by in this phase, or cancer is responsibly or cancer is coming from in this stage, then we can successfully stop at that stage by some of the factors which are responsible for stopping there, that are cell cycle with the specific drugs. Okay, some cancer which may be detectable if we detect earlier, like if the cancer is coming from S phase or G2 phase or M phase, then there are some drugs which will inhibit them at S phase inhibitors. And here M phase inhibitors. Okay, here we will come across some S phase as well as M phase inhibitors. In this, there will be a specificity of cancer and drugs which will stop the cancer at that stage of cell cycle and cell division. But there are some antibiotics or some anti-cancer drugs which are non-specific. Like if a doctor come to know like is not specified to some of the cancers, like he don't know the basal reason, then generally he have to give the chemotherapy. Then you will be using some of the drug, they are called as alkylating agent. And platinum compounds, as well as anti-tumor antibiotics. So let us come across some S-phase inhibitors. Okay, let us come across some S-phase inhibitors. S-phase inhibitors are S-phase inhibitors are antimetabolites, those are antifolate, pyrimidine analogs, and C-purine analogs. And topoisomerase inhibitors, hydroxyurea, histone deacetylase inhibitors, see, as you see here, like topoisomerase, hydroxyurea, and histone deacetylase isomer. Is the idea we will coming across some DNA replication or something like that. See, topoisomerase and histone, these are used in DNA replications, as well as some RNA, like topoisomerase, which is used for the non-tensioning of DNA while unwinding. So these all factors which will be responsible for DNA replication. And here the correlation is in the S phase, there will be a DNA replication. So these are the S phase inhibitors. If they inhibit the topoisomerase, then how can that tension will be free at the DNA while unwinding? And histone protein, which are responsible for the packing of a DNA into a chromosome. So if we will inhibit that, then how can then the S phase will be failed there. So after the inhibiting that, S phase will fail. So that will inhibit that one there. These are responsible for the inhibiting S phase. Let us take the M phase. M phase inhibitors. Vinca alkaloids, taxanes, epithelons, eribulin, stramotase, So these are the M phase inhibitors. After taking all these inhibitors as well as chemotherapy, is that we are not prone to some side effects? There will be a side effect because we go to the base of the body production where the cell is produced. We go to the basic thing of the body where the cell is produced, either in the bone marrow or something there. So normally the cell will be producing and making their physiological functions. So we go across that and we will make the cell cycle to be stopped there for our profit, in the manner to stop some cancer cells. Like those don't have any brains. See, these drugs don't have any brains to stop the cancer and the non-cancer one producing cells. So they simply go and inhibit the S phase as well as M phase. So then there will be a lack of physiological factors in the body, like while producing the blood might in the bone marrow, the WBC cells. So many cells which will be producing under bone marrow or somewhere in the body, like the production of the cells, there will be a stoppage or there will be a delay in production of the cells due to destroying of M phase as well as the S phase. So then there will be a side effects. Okay. So primarily, if you want to take the side effect, common side effects. They block the replication. And then there will be a bone marrow suppression. The most common is here. The most common one we will come across is like most common dose limiting toxicity. Of anti-cancer drug. Maximum with alkylating agent. Antifoliates drugs. And we never we don't see these bone marrow suppression in the drug like cisplatin. And crystine. Bleomycin. We don't see some of these most common side effects. These bone marrow suppression, we don't see these type of anti-cancer drugs. Okay. And the most common one that you will be observing, like hair follicles will be lost. Okay, these hair follicles will be lost. That is called as alopecia. Okay. Hair follicle will be lost. That is alopecia. And germ cell. So in this germ cell there will be a oligospermia, aovulation, anovulation, that leads to the infertility. GAT mucosal cells, Geralbia, mucositis, diarrhea, and the important factor and the feasible things comes here. ECL cells, enterochromaffin cells, lysis. Okay, these enterochromaffin cells lysis will leads to the release of serotonin and substance P. And you generally know the release of serotonin and this substance B leads to the stimulation of 5-HT3 complex and neurokinin 1, which leads to the nausea and vomiting. In 90% of cases, we will be coming across this nausea and the vomiting by giving some of the drug like cisplatin. Okay, now the example is the person is suffering from the cancer, okay, and he is not eating properly and he has to take some chemotherapy drugs. So if he has to take the chemotherapy drug every time, like we can't induce him IV line and making him or giving him the energy by some drips or something else. Now he has to eat something. Then there should be a reduced nausea as well as vomiting. Now, so that we have to give some drugs for this nausea as well as vomiting to prevent this. Nausea and vomiting. So to prevent this nausea and vomiting, we will give for 5-HT3 blockers. These are ondansetron, polosetron. Okay, this ondansetron is short acting. Drug of choice for early onset of nausea and vomiting. So these are 5-HT3 blockers, ondansetron and palosetron. So this ondansetron is a short acting and the drug of choice at early onset of nausea and vomiting. So the person is suffering from initial stage of vomiting as well as nausea, then they will be suggested with the ondansetron. But if a patient persistently is vomiting and nausea, is suffering from nausea and vomiting persistently more than a week, then they will be changing the drugs to the palosetron. Then they will be changing palosetron. And with that, neurokinin 1 blockers. Why they are suggesting neurokinin 1 blocker as well as 5-HT blockers? Because those are responsible for the nausea and vomiting, which is caused by the release of serotonin as well as substance P. Okay, this is a short limit there. And here for this neurokinin blocker, these drugs are long acting drug of choice for nausea and vomiting. So overall, overall we will be suggesting ondansetron as well as dexamethasone, D2 receptor blocker, metachloropramide, antipsychotics. One is typical, atypical. Typical is prochlorperazine, and atypical is olanzapine. Here we come across cannabinoid receptor agonists. So these all are drugs which are responsible for controlling nausea and vomiting and making patient to take the chemotherapy drugs or anti-cancer drugs, okay, to cure. These are antiemetic. Okay. And these drugs are antiemetic. By this antiemetic, like side effect will be hypotension, okay, as well as bloodshot eyes. Here no action on alpha 1 vasodilation. So this will be the cause, okay. And regimen for the chemotherapy induced nausea and vomiting. So we will talk about the regimen now, okay. Make a box here. Here we'll be writing severe, moderate, mild. This is the regimen for chemotherapy induced nausea and vomiting, okay. Ondansetron, dexamethasone, triptant, olanzapine. So these are taken when there will be a severe condition of nausea as well as vomiting. But ondansetron and dexamethasone and triptant is enough for the moderate nausea as well as vomiting In the mild, either you will take ondansetron or dexamethasone. So this will be the drug of choice during the nasal vomiting during the chemotherapy. Firstly, we will discuss about some non-cell cycle specific drugs. Okay. Cell cycle specific drugs. These are, as we discussed there, they are alkylating agent. See here, I want to explain something. So there is a DNA here. Okay. Sorry. See, you think this has a DNA? Okay, there is a DNA. These alkyl group are devoid of H atom, hydrogen atom. Okay. Now they have to bind with something hydrogen there, free hydrogen or something hydrogen which is available in the DNA. So what they will do, they will directly go and bind to the nitrogen 7 of the guanine. Okay, here the guanine, it will be attached with the hydrogen. Okay, guanine normally with the triple bond it attaches with the cysteine. But the thing is, the one of the hydrogen bond is attached by some alkylating agents. So these alkylating agents which are responsible for the guanine to attach to the thymidine, which is totally abnormal. The nitrogen 7 place which is in this DNA chain, which undergo attachment with the extra hydrogen of the alkyl group, and the guanine which is left out with some non-hydrogen one, which will go and attach to the thymine because of the double hydrogen bond are left. Okay, so it will be abnormal then. Okay, after the abnormal one, there are some check gates at G1, S, G2, mitotic phase. There are some check gates. Okay, CT, CD, something like check gates at something like after G1 and after G2. There are some check gates. There, as there is some defects in the DNA, that after the S phase it won't allow to undergo the mitotic phase. So if it is functional, if it does not allow. If it is non-functional, or some like a 2% of the DNA which is left untranslated, if it is like that, then it will lead to the secondary cancer, which is also called as AML, acute myeloid leukemia. 4 years it takes to develop. Okay, to develop it takes 4 years. Did you understand this? So if the checkpoint is non-functional, then there will be a cancer. If checkpoint is functional, then that DNA will be non-functional. So this is the broad spectrum of the non-specific cell cycle, non-specific cell cycle destroying drugs. This is the defect. Either if it is non-functional, then he'll be suffered from the acute myeloid leukemia in the future days. Most common complication with this is most common complication with the drug melphalan, and least common, this is most common one, and the least common one will be like cyclophosphamide. This is the least common. Okay, and if you want to discuss about some alkylating agent classification, so you make a note of four groups. Okay, make a note of four groups. These four groups. The first one is nitrogen mustards. And the second one is nitrosourus ureas. And the third one is agents acting by DNA methylation. The fourth one is general. Okay. If you want to discuss the drug which are under the nitrogen mustards, cyclophosphamide and ifosfamide. Okay, cyclophos and ifosfamide. So these are the two important. If you take first one, cyclophosphamide, it is used for the pediatric solid tumor or Wilms tumor, neuroblastoma. And as well as breast cancer, ovarian cancer. This drug is used there. Okay. And as well as CLL, non-neoplastic. Drug of choice, Vaginas as a drug of choice for vaginal granulomatosis, and as a drug of choice for steroid dependent nephrotic syndrome. Okay, and infection bowel disease, and used in osteosarcoma, testicular cancer. So there are many uses of this. Okay. So this was up to cyclophosphamide. From this, ifosfamide will be there. phosphor from here, I for phosphoride. Okay. The other applications are here. The side effect here, the side effects are hypophosphamide. Hypophosphamide have more side effect than cyclophosphamide. Okay, these produce more toxicity, will be more. Okay, like hemorrhagic cystitis, neurotoxicity. Okay, like seizures, there will be more side effect with this one. Okay, this is prevented by mensa. This is the drug name is mensa. This drug, this drug, which will be given with the oral by IV, like 60% of dose. If the dose is given 100%, then 60% should be given of this dose. Okay, and other drugs are like, after that, cyclophosphamide as well as ifosfamide. We can have the other drug with this nitrogen mustards or melphalan, multiple myeloma, chlorambucil. This is for chronic lymphoid leukemia. Okay, these are the things for this nitrogen mustard. Nitrosoureas. For the nitrosoureas, the drug consists of tain. These are only tain. Simostine, lomostine. So advantages of these drugs are highly lipid soluble, highly lipid soluble, and cross blood-brain barrier. Used in brain tumor. But side effects are sustained neutropenia. The other drug which is used in this is streptozocin. This is used in malignant carcinoid tumor, pancreatic beta islet cell of cancer. Okay, these are the ones which are used on nitrosoureas. Agent acting by DNA methylation. Okay, these are important, quite important. These are dacarbazine, procarbazine, Hodgkin's disease, drug of choice. Side effect will be by procarbazine, weak MAO inhibitors, which will lead to cheese reaction. Okay, then there will be hypotension, the cheese reaction which is responsible for the hypotension, and serotonin syndrome. Temozolomide. This temozolomide, drug of choice for brain tumor. The miscellaneous one are quite easy. Busulfan, used in chronic myeloid leukemia. Side effect are pulmonary fibrosis. Okay. Thiotpa, trabectedin, tetamine, used in drug resistance of ovarian cancer. So this is the end of this non-specific cell cycle drugs. Okay, this is the end of this lecture as anti-cancer drugs. The part is non-cell cycle specific drugs. And cell cycle specific, in that non-cell cycle specific drug, alkylating agents we explained, and platinum compounds and anti-tumor antibiotics will be explained in the future classes. Thank you. Namo Venkateshaya. Classification of anti-cancer drugs. As you know, these antimetabolites, topoisomerase, hydroxyurea histone, M-phase inhibitors, vinca, dithiophorobin. Okay, and the common side effects, as you know, there will be hair loss and bone marrow suppression, as well as there will be nausea and vomiting. To prevent nausea and vomiting, we will be giving dexamethasones and some of the drugs like aldosterones, not aldosterones, aldosterone, dexamethasones, aprepitant, okay, and olanzapine. These drugs we will be giving for them, and these are the drug of choice for them, for severe, moderate, and mild. And alkylating agents acting like hydrogen, it will be going to the N7 term of the, and it will be going and attaching to the glycine, gonine, that gonine, it will be non-functionally attaching to the thymine. If it is functionally, then it will be going to the checkpoints and it will be kicked out. If it is non-specific or translated in a region, then after the 4 years you'll be suffering from the acute myeloid leukemia. And these are some of the nitrogen mustards, nitrosoureas agent acting on DNA methylation. So these are the alkylating agents, non-specific cell cycle drugs, are like cyclophosphamide, iphosphamide, okay, sumocysteine, levostin, and dicarbazine and procarbazine, busulfan. Thank you. Om Namo Venkateshaya.